Healing of oral wounds. Factors affecting healing of oral wounds are three factors. They are physical factors, hormonal factors, and miscellaneous factors. Okay, so let's start with first physical factors. Anatomical site. If it is movable site, then it will delay the wound healing. If circulatory factors, less vascular area, delay it. Nutritional factors, if less of vitamin C and B, or it will delay it. If age of the patient is more, then it will delay the wound healing. Infection, microorganism, toxic products released by microorganisms, it will delay the wound healing. Hormonal factors, cortisone and ACTH levels increase. If cortisone and ACTH level increase, suppress inflammation and delays wound healing. If cortisone and ACTH level increase, then it will delay the wound healing because endothelial cell proliferation, decreased proliferation of fibroblast will be delayed. Insulin, if decrease in insulin, then diabetes mellitus will occur and it will delay the wound healing. If these hormones, cortisone, ACTH, and insulin decrease, cortisone and ACTH level increase, then it will delay the wound healing, and if insulin decreases, then it will delay the wound healing. Miscellaneous factors. Suture material, foreign substance at site of material, it will delay the wound healing. Enzyme, trypsin, streptokinase, etc. delay the wound healing. Trypsin and streptokinase will delay the wound healing. Okay. Then complications of wound healing: infection, keloid and hypertrophic scar formation, overgrown scar tissue with no tendency for resolution or resist. Increased fibrous and vascular tissue undergo resolution. Oral wounds neither show keloid and hypertrophic scar formation because of good vascular supply. Oral wounds. So keloid and hypertrophic scar are the complications of wound healing which overgrow scar tissue with no tendency for resolution, increase fibrous and vascular tissue undergo resolution. Okay. Then pigmentary changes, area of hyperpigmentation. Hypopigmentation can be seen, hypo or hyper. Implantation of cyst. Epithelium gets entrapped at the time of wound healing, forms cystic cavity. Example, surgical ciliated cyst of maxillary sinus. Surgical ciliated cyst of maxillary sinus. Then healing after pulpal diseases. Most common manifestation after pulpal diseases. So most common and pulpitis. If pulpitis occurs, three things will happen. Sorry, four things. First is necrosis of pulp. Majority of the pulp will be necrosed. Then second is the normal pulp will be present, reversible pulpitis. Then third is stimulus odontoblast, tertiary dentine formation, and then fourth is undergo fibrosis, reticular atrophy of pulp. Okay. Undergo fibrosis because of age-related phenomena or trauma prematurely, etc. are the reasons. So a pulpitis can manifest into four things: necrosis of the pulp, normal pulp, reversible pulpitis, and stimulus odontoblast, tertiary dentine formation, undergo fibrosis, reticular atrophy of pulp. Okay. Then healing after periapical diseases. Most common periapical lesions seen in association with a non-vital tooth, periapical granuloma, resorption of root, resorption of bone. Root apex healing, hypercementosis may occur, and anatomical repair. Periapical granuloma formation, resorption of root apex healing will cause hypercementosis and anatomical repair. And resorption of bone, periapical radiolucency undergo healing, bone deposition. bone deposition, bone sclerosis, when all toxins and inflammatory mediators have been removed from that side, then it will cause bone deposition and bone sclerosis. Okay. Biopsy and healing of biopsy wounds. Type of biopsy: incisional and excisional biopsy. Incisional, large lesions, diagnostic biopsy. Excisional, small lesions, curative biopsy. Healing of biopsy wound: wound healing by primary intention and secondary intention. Okay. When two ends approximated, clear incision is with scalpel, decrease granulation tissue formation. Two ends far apart, increase granulation tissue. For formation of granulation tissue beneath the clot, inflamed connective tissue will have granulation tissue will have inflamed connective tissue, which consists of increased amount of capillaries, increased amount of endothelial cells, and increased amount of inflammatory cells. Exfoliative cytology. Exfoliated cells, study of cells. Exfoliative means exfoliated cells and study of cells. Study of cells of exfoliated cells. Okay, desquamated cells. Okay. Now, stratum corneum, stratum granulosum, stratum spinosum, and stratum basale are the layers which is proliferating. Okay, pathology present reflected in the stratum basale, and they lose their cohesiveness and gets exfoliated. So we collect these exfoliated cells. So first we scrape the lesion and then transfer on glass slide, dip it in alcohol and ether mixture fixator. Then air dry it. Drying with heat may destroy the oral lesions. Stain it with most common stain used is pap stain. Then name after scientist Sir George. The stain named after scientist name Sir George Papanicolaou. Okay, then observe under microscope. Divide it under 5 classes: first class, second, third, fourth, and fifth. Okay, so first class is normal, second class is atypical, minor atypia, a few cells showing cellular atypia. A few cells showing cellular atypia. Class 3 intermediate, few cells are normal and few cells are atypical. Potentially malignant disorders, carcinoma in situ. Biopsy is recommended but not mandatory. Class 4 suggestive of cancer, quite a number of cells which are atypical. Biopsy is mandatory here. Class 5 positive for cancer, all cells are malignant. Biopsy is mandatory, but still not a confirmatory test. Exfoliative cytology is not a confirmatory test. Adjunct and a non-definitive act as adjunct and non-definitive. Definitive diagnosis is only made after histopathological examination. Difference between exfoliative cytology and brush border biopsy. Brush border biopsy is better picture. Here in exfoliative cytology, no force applied, not deep, only on surface. Basal epithelium gets exfoliated. Here collecting of the cells. Here we use cyto brush scraping hard. We are going into deep transepithelial region, basal and suprabasal layer. Better prognosis will be shown by basal layer. Here plucking of the epithelium. Healing of gingivectomy wounds. Early healing phase. Bleeding will occur, clot will form, inflammatory changes will occur, and vasodilation will occur. Oral wounds, wound healing in general body. Wound healing in general body. Then late healing phase. Complete organization of clot after 10 days. Complete organization of clot after 10 days. And complete organization of clot after 10 days, then epithelium is usually complete within 10 to 14 days. Complete organization of the clot after 8 to 10 days. Clot will form completely in 8 to 10 days, and then epithelialization is usually complete within 10 to 14 days, and then radipegs only after a 2 week interval will occur. Gingiva got long and thin radipegs. Okay. Healing of extraction wounds. First 7 days, it is very important. Okay, blood clot begins to organization. Proliferation of fibroblast will increase. Initiation of granulation tissue. Then epithelium at periphery shows mild mitotic activity. Alveolar crest osteoclastic activity will occur. Mitotic activity will be seen. Epithelium at periphery. Second week, 7 to 14 days, blood clot becomes organized. New capillaries penetrate the clot. New capillaries will penetrate the clot. In smaller socket, epithelialization complete. The margins of the alveolar socket exhibit prominent osteoclastic resorption. Then in third, 14 to 21 days, very young trabeculae of osteoid form around the entire periphery. The crest of the alveolar bone is rounded off by the osteoclastic resorption. Surface of the wound completely epithelialized, small or large. Fourth week, 21 to 28th day, 21st to 28th day, continued remodeling of bone becomes radiographically evident after 6 to 8 weeks. Difference between normal bone and extraction socket is seen in 4 to 6 months after extraction persists only. Difference between normal bone and extraction socket: 4 to 6 weeks, 4 to 6 months after extraction persists. Then dry socket. Dry socket, also called as alveolitis sicca dolorosa, localized acute alveolar osteomyelitis, and alveolar osteitis. Alveolar osteitis. Okay. Then starts at second to third day post extraction. Most common complication and very painful. Etiology is dislodgement of clot. Two theories: plasminogen dependent pathway or plasminogen independent pathway. Plasminogen get activated to form plasmin, cause lysis of clot. Plasminogen gets activated to form plasmin, cause lysis of clot, which cause lysis of clot. Okay, plasmin is the reason why clot dislodge or lysis occurs of the clot, and that's why dry socket occurs. Treatment: packs given. Iodoform packs and eugenol packs are given, usually seen in association with mandibular third molar extraction. Then myocherulosis, foreign body reaction. For treatment of oral wounds, antibiotics are mixed in petroleum jelly at a wound, used as localized drug delivery. Petroleum jelly incites the local foreign body reaction. Then seen in form of intense inflammation. Compared with spherules and bag of marbles, then seen in form of intense inflammation, then RBC appear vacuolated compared with spherules and bag of marbles. Healing of bone fracture, complication of fracture healing, and Distraction osteogenesis will be covered in general path and oral surgery. Healing of bone fracture, complications of fracture healing, and distraction osteogenesis. Replantation and transplantation. Replantations is replanting an avulsed tooth in same socket. Replanting an avulsed tooth in same socket. Reason: trauma, intentional extraction. Replanting an avulsed tooth in the same socket. Replanting an avulsed tooth in the same socket. Reason: trauma or intentional extraction. Okay, usually seen in children. Tooth come out, periodontal ligament is viable. Keep in specific transport media. HBSS, Hank's balance or salt solution, or milk, saliva, saline. Then transplantation, moving one tooth to another side. Most common, developing third molar seated into first molar, and first molar is extraction taking place or missing. Implants. OS, perio and prostho will be covered in OS, perio and prostho. Okay, here also we are doing this. It osteointegration, direct union between implant and bone. Direct union between implant and the bone is called as osteointegration. Osteointegration, a type of ankylosis. Periimplantitis is bone loss plus soft tissue infection, and perimucositis is only soft tissue inflammation. Bone loss and soft tissue inflammation is periimplantitis, and perimucositis only soft tissue inflammation, no bone loss. Stem cells of dental tissue. Regeneration of entire tooth has become a possibility. Dental pulp of secondary teeth, DPSCs, dental pulp stem cells. Dental pulp of secondary teeth. Dental pulp of secondary teeth are DPSCs, dental pulp of stem cells. Naturally exfoliated primary teeth, stem cells from human exfoliated deciduous teeth. Stem cells from human exfoliated deciduous teeth, SHED. Then periodontal ligament stem cells, PDLSC. Apical papilla, stem cells from apical papilla, SCAP. Dental follicular PC means dental follicular pulp cells. And then periosteum of maxillary tuberosity. Periosteum of maxillary tuberosity is very important because we take as a grafting purpose from there. So oral periosteum stem cells. Okay, oral periosteum stem cells. That's it. Thank you.